Hello. In my earlier lectures, I have talked about the clinical features, the assessment, and management of refractive errors with the help of spectacles. Today, I will talk about the indications and general principles of refractive surgery. The purpose of this lecture is to apprise you of the various types of refractive surgeries and the procedures. It is not to make you proficient in the various refractive surgical procedures. For that, you will have to read and attend the surgical sessions for the specific type of surgery. So let us go ahead with the understanding of the treatment of refractive errors with the help of refractive surgery. Unlike the spectacles, which help to improve the vision with the help of glasses, the purpose of refractive surgery is to eliminate the need of glasses by modifying the refractive power of the cornea or the lens. Refractive surgery is needed more often for myopia than for hypermetropia. The main indications for refractive surgery is number one, the patient wants. And he may want it for functional reasons. For example, the patient feels difficulty in wearing glasses all the time and day-to-day activity gets affected without glasses. When the patient is unable to wear glasses for his regular activities, as in some sports. He may also want it for cosmetic reasons, that he just does not want to wear glasses. Now, the patient wants is not enough. We as surgeons have to look into the suitability of the surgery for the given patient. And let us go ahead to see what are the criteria for selecting patients for refractive surgery. For refractive surgery, patients should be chosen with care. Of course, a motivated patient is the first criteria. Then, as surgeons, we should proceed with refractive surgery when the refractive error is stable. This usually happens around the age of 18 to 20 years. When not sure, the patient should be followed up for about a year to ensure that the refractive error is stable. For cornea-based surgery, corneal thickness should be 450 microns or more. There should be absence of a corneal pathology and absence of corneal ectasia. Thin cornea and corneal ectasia are absolute contraindications for cornea-based refractive surgery. Let us look at the various refractive surgical procedures. Here we see a whole list of them. Those highlighted with these red marks are the ones which are in use today. The others are sparingly used or not used at all. The attempts to correct refractive error surgically were on since the early years of the 20th century, and mostly they were mechanical in nature, which involved reshaping of the cornea with the help of microkeratome. With the FDA approval of lasers for use in refractive surgery in 1998 and the promising results that it gave, it almost took over all the other types of surgeries. So let us look at the cornea-based procedures. They are reshaping of the cornea with the help of ablation or lenticule extraction, the help of an incision, thermal keratoplasty or implantation of intrastromal corneal ring segments. The lens-based procedures are implantation of a phakic refractive lens or refractive lens exchange. In the cornea-based procedures, the ablation, the laser in situ keratomiliosis or LASIK is the most popular surgery. The others are LASIK, photorefractive keratectomy and automated lamellar or epikeratoplasty. Instead of ablation, there can be a extraction of a small lenticule of the cornea, and this is called refractive lenticule extraction, RELEX, or a small incision lenticule extraction, or a SMILE. In the incision based, the relaxing incisions at the limbus or at the cornea are still in use. The other two procedures, radial keratotomy and astigmatic keratotomy, have been almost given up. Thermal keratoplasty and intacs are used sparingly, and the implantable lens or the refractive lens exchange, they are used in selected patients. We will see their indications later. So we have the often used procedures, which are LASIK, lenticule extraction, implantable contact lens, and limbal relaxing incisions. The less often used in selected patients are photorefractive keratectomy and refractive lens exchange. The sparingly used procedures are intracorneal implants and thermal keratoplasty. And the procedures which are not done now are automated and epikeratoplasty, radial keratotomy, and astigmatic keratotomy. The purpose of refractive surgery for myopia is to somehow reduce the curvature of the cornea or the converging power of the lens. LASIK is most commonly performed surgery. Refractive lenticule extraction or small incision lenticule extraction is the more recent technique to achieve the same. Implantable contact lens or phakic IOL is indicated in people who are not good candidates for cornea-based refractive surgery. Refractive lens exchange is indicated in high myopes. In general, the need of refractive surgery for hypermetropia is not as common as that for myopia. For most of the hypermetros are able to perform their day-to-day functions, particularly for distance, even without these spectacles. The aim is to somehow increase the curvature of the cornea or to implant a suitable lens to increase the effective convergence. Most of the corneal surgeries for hypermetropia are effective for smaller errors up to 4 diopters. In exceptional cases, maybe up to 6 diopters. The procedures are as follows. The cornea-based procedures are hyperopic laser and thermal keratoplasty. Laser thermal keratoplasty, in this 8 laser spots are applied in a ring at the periphery of the cornea to produce central steepening as shown in figure 1. Regression and astigmatism are main problems. Conductive keratoplasty or CK uses radio frequency energy. The lens-based procedures are phakic refractive lens or PRL, in which a appropriate lens is implanted over a physiological crystalline lens, and refractive lens exchange, where the crystalline lens is exchanged for a artificial lens of another power, and this is indicated in high hypermetropes over 40 years of age who are unsuitable for LASIK procedure. This shows the 8 laser spots in the periphery of the cornea which result in scarring and steepening of the central part of the cornea. LASIK or laser assisted in situ keratomileusis is most commonly performed for myopia correction. It is used to treat hyperopia as well as astigmatism. Front surface of the cornea is reshaped by laser ablation of corneal stroma under a thin superficial flap, as shown in figures 2a and 2b. A microkeratome or a femtosecond laser is used to create a thin circular flap in the corneal epithelium. This hinged flap is folded back to access the underlying corneal stroma. An excimer laser is used to ablate pre-calculated amounts of microscopic tissue from the cornea to reshape it to achieve desired refractive power. The corneal flap is repositioned back in place where it adheres to the corneal stroma without stitches. Smile or small incision lenticule extraction. It is also called refractive lenticule extraction, RELEX, is a newer laser refractive surgery. It is considered better than conventional LASIK as it does not require reflecting a superficial flap, hence the surface of the cornea is minimally disturbed. With the excimer laser, a pre-calculated shape of lenticule is fashioned in the corneal stroma, and this corneal stroma lenticule disc is removed through a very small incision as shown in figures 2a and 2b. This figure shows the size of the superficial corneal flap in LASIK. Now this flap is hinged back for ablation of the superficial corneal stroma, whereas in RELEX this incision is small and a lenticule of the cornea is fashioned beneath this. This is removed through this small incision. So the corneal epithelium is minimally disturbed and hence the post-operative discomfort is also minimal. Now, as I said earlier that this laser surgery can be done for myopia as well as for hypermetropia. Now the surgery is used only, the results are different only by modifying the shape of the lenticule. So this is the shape of the lenticule which is extracted for correction of myopia, and this is the shape of the lenticule. See, it is thicker in the periphery and thinner in the center, which is extracted for hypermetropia. As I have said earlier, the refractive surgery is more frequently required for myopia correction than for hypermetropia correction. Now this is a representation of the same as shown in figure 2a. You see the large circular flap which is hinged back on itself for LASIK procedure, and you see this small incision opening in the corneal flap through which, using laser, a lenticule of the corneal stroma is fashioned and extracted. There are certain important factors about corneal thickness that should be known before planning a corneal ablative procedure. Normal central corneal thickness is 500 to 550 microns. More than 550 microns is considered thick, and more than 600 microns is considered very thick. LASIK and cornea ablation procedures are contraindicated in patients who have a corneal thickness of less than 450 microns. Also remember that residual corneal stroma after surgery should be about 275 microns or more, but never less than 250 microns. And residual corneal thickness should be about 375 microns. 14 to 16 microns cornea is ablated for per diopter of correction in the refractive error. So accordingly you can pre-calculate how much thickness of the cornea would be required to ablate to get the desired correction depending upon the refractive error, and you can have an estimate of the residual corneal thickness that would remain after ablation. Intacs or intracorneal ring segments are small, clear, semicircular inserts that are surgically placed in the corneal stroma to flatten it. This is shown in figure 3. They have a limited use in the treatment of myopia, astigmatism and selected cases of moderate keratoconus. They improve the uncorrected vision and make the corneal curvature more suitable for contact lenses. Here we see the intracorneal ring segments placed on the finger, placed in the corneal stroma, and here we see the effect of the intracorneal ring segments or intacs on the corneal curvature. So this is before the application and this is after the application. Let us look at the guidelines for the amount of correction achieved by various procedures. LASIK, RELAX or SMILE can correct a myopia of -8 to -11 diopters, the amount depending upon the basic corneal thickness. Hypermetropia of +3 to +4 diopters can be corrected by LASIK and an astigmatism of about 5 diopters. PRK or LASIK can correct -6 diopters of myopia and up to +4 diopters of hypermetropia, and astigmatism also of up to 4 diopters. Intacs can correct a myopia of less than 4 diopters. The phakic IOLs are used in refractive errors of higher order that cannot be corrected by LASIK, or in patients who are not suitable for corneal procedures. They can be used for myopia any range from -5 to -30, and for hypermetropia from +3 to +15, and they can correct a astigmatic error of up to +10 diopters. Of course, these very high numbers are usually not needed, but they may be indicated in an odd patient. The refractive lens exchange is obviously a choice for very high errors, and in which the clear lens is extracted and is replaced by a intraocular lens implant. Refractive surgery for astigmatism is illustrated in figure 4a and 4b. Astigmatism correction can be done alone or along with other refractive surgery. Astigmatism can be corrected by limbal or corneal relaxing incisions. Linear cuts are made on the ends of the steeper meridian in the limbus or corneal mid-periphery. This corrects up to 2 diopters of astigmatism. Corneal relaxing incisions are performed usually by knife but can be done by laser too. This figure 4a illustrates the effect of the limbal or corneal relaxing incisions. So here is the cornea with the steeper vertical meridian. The relaxing incisions are made at the ends of this more steep meridian. So it may be at the limbus, which is this shown by these lines A, or it may be in the mid-periphery as shown, mid-periphery of the cornea as shown by these lines B. And the effect is that it makes the steeper meridian less steep. The cuts should be at least 50% deep. Do not cut deeper than 90% depth, and it goes without saying that the deeper cuts have more effect. There is a coupling effect of limbal or corneal relaxing incisions. Along with the flattening of the steeper meridian, there is a steepening effect on the less steep meridian. As you see in this figure, The steeper meridian has a power of about 45 diopters and the less steep meridian has a power of 43 diopters. Now, after the relaxing incisions at the ends of the steeper meridian, this power has reduced to 44 diopters, whereas this power of the other horizontal axis has increased from 43 to 44 diopters. So this is the coupling effect. Similar effect you can see in this picture as well, where the horizontal meridian is the steeper meridian. There is very little demand for surgical correction of presbyopia. Hence, this surgery is still not very evolved. However, following methods are being tried. Monovision, one eye is corrected for near and the other for distance by any of the above described procedures. There are multifocal or accommodating IOLs. The Presby LASIK bifocal or multifocal is still not very popular. The aim is to alter the shape of the cornea to have two concentric vision zones, one for near and other for distance, as shown in figure 5. Some sclera-based procedures to expand the sclera and ciliary zone are also being tried. The aim of this particular session is not to go into details of the surgeries which are still being evolved. This figure illustrates that by modifying the laser ablation, you can create zones for near vision and far vision. So here we have near vision correction for in the center and a peripheral zone for far vision. This is a peripheral vision for far, and the center one is corrected for far vision and the peripheral zone is for near vision. So these patterns basically are chosen on the basis of the patient's requirement and also on the basis of surgeon's preference. Let us now revise and also test our understanding with the help of MCQs. You can go ahead to attempt these MCQs. The key is given at the end.